Okay, we'll get started. So nice to see you all. Thanks for coming. Uh, I've learned that even when it's a little sparse crowd at first, it kind of builds after a few minutes. So, welcome back, and so glad you're here. I think that you'll enjoy this presentation. I think it's a little different than most. It's going through the recommendations. What are the standard recommendations for prevention and for health maintenance and this kind of thing? And you've got to wonder sometimes when we doctors spit out, no, this is due then, and this is, and why is that? I'm an individual, and you're treating me like I've got to have everything done like the masses. And there is an element of that to it. But it is all based on the best studies. So today's presentation will lean, you'll notice on the slides, will lean pretty heavily on the U.S. Health Services Task Force on recommendations for promoting healthcare, or promoting health. And hopefully these guys are going to be able to kind of share why these individual recommendations rose to the level of being universally recommended. And there's a few areas of controversy, and we don't all have to do the cookie cutter thing. We do try to individualize it to folks in their particular set of health risks, but at least in our minds, we have to have a good justification if we're going to say, no, you don't need to do that, even though it's recommended. So that's kind of where we are, and I thought it might be useful to y'all, since I'm sure at times you feel like the victims. Scoping, I said never another scoping. That's the way we all feel about that, isn't it? If we could learn to do a scoping without the prep. No one ever complains about the scoping. You sleep right through that. It's the prep the night before. So anyway, with that, let me introduce our residents who are here with us on this new schedule. You've heard we've kind of got a new schedule. So used to be the residents were here two residents were here in the clinic for 4 weeks at a time, and they'd only be here once a year. So we won't see them until next year. Now we've got 8 residents coming 2 at a time and rotating. Two residents, these 2 residents are here for 2 weeks, and then 2 residents replace them for 2 weeks, and then after an 8-week cycle, they're back. And so instead of once a year, these guys are here 6 times a year. So you have they have an opportunity to get to know you individually better, and vice versa. So we're trying this, and we hope it'll be good for everybody. I'm still getting used to it, I can tell you. That old dog, new tricks thing, practicing. Well, let me introduce these residents. So as you know, we usually have an upperclassman and a first year, usually. And today the upperclassman is, see, he has the convenience, he has the privilege, he sits. Since the first year guy, the intern up first, Joseph Kuhn has been with us. This is his 3rd year, so it's his last year in the program. He's a native Arkansan from Central Arkansas, though, from small town south of Little Rock. He went to UAMS. Actually, for college, he went to Ouachita Baptist University. It's a great school in Arkadelphia, and to UAMS. The other thing I can tell you about him is he has 2 beautiful daughters, beautiful wife, 2 beautiful daughters, Eleanor, the 2-year-old, and Miss Charlotte, the 2-month-old, 2 or 3-month-old. He has busy nights as well as busy days. Anyway, he's been great in our program, and we'll have him out here regularly in his last year. He's been great. And then some of you may recognize this young whippersnapper. The first year Dr. Osborne, Hayes Osborne, grew up in Fayetteville. His parents, his grandparents, many people know his father, who's a periodontist, right, in Fayetteville, and his grandfather, so many people, even more people know, is a prominent attorney in Fayetteville. He's married as well, and his wife is a physician. She's going through training to be a psychiatrist. Now he won't see her tonight to tell her about all of you, because she's doing that residency in Baton Rouge. Hey, you can go to the ball game if you can get down to see her this weekend. You can go see the Hogs. So you're missing the comments on the front row of, he's precious, I know him, I watched him. We believe you. We believe you. Okay, well, with that, and the other wonderful thing I can tell you about Dr. Osborne is he went to my alma mater, undergraduate, Hendrix College in Conway. So we have OBU and Hendrix represented. I like that. So with that, we'll let Dr. Osborne lead us off.
Hi. You'll have to forgive me. I'm not the best public speaker, but we'll get through this together. I always have that I'm precious. All right, so some of the first recommendations we want to talk about are with regards to bone mineral density. This is specifically assessed in women. The most common method is by DEXA scan, which stands for dual energy X-ray absorptiometry. Quite a mouthful, so let's stick with DEXA. This is very important. As we age, our bone density decreases and becomes more brittle. This is especially true in women after menopause. So it's very important. We recommend at least once after the age of 65 getting a scan to see kind of where you're sitting at in terms of bone density. With regards to breast cancer, there are medications that can be provided in women who represent greater risk for developing breast cancer to hopefully prevent development of the disease. This is particularly targeted at individuals with known additional risk factors, genetic history, family history. Yes. Okay. And to further illustrate my point earlier about bone mineral density in men and women, you can see here this blue line representing males' bone mineral density and females here sharply dropping around the time of menopause. And in fact, as age progresses, you can see that it takes several years for men's average density to equal peak density in women, highlighting how important the risk really is and why that's prioritized specifically for women. But should men demonstrate evidence for osteoporosis, it still might be warranted to receive a DEXA scan. Okay, COVID-19 vaccination. I think we've all heard something about that at some point in the last few years. And so I won't belabor the point too much, other than to say a pretty common thought process is, well, I've had it before. I had the infection, why would I get the vaccine? What we are finding is a recent study in Nature showed that with each subsequent COVID infection, there is worse morbidity, mortality, and suggestions of greater risks for developing diabetes, chronic kidney disease, organ failure, and mental health problems after the fact. So it's very important to still follow through with a vaccine. Okay. And yes, diphtheria, pertussis, and tetanus vaccine, we recommend this every 10 years. This is based on the fact that studies have shown that immunity gradually decreases over time. And so with antibody numbers decreasing with each passing year, so we like to re-up you every decade or so. Okay, here we have influenza, herpes zoster, pneumonia vaccines. These are done, we all know, getting our flu shot every year. Herpes zoster is done every year after the age of 50, and pneumonia vaccination series once after the age of 65. It's very important to follow through with all of these vaccines, especially into older age, as the risk for more complications and more dangerous complications goes up with each year. Hepatitis A and B screening. This is done at least once in individuals that represent high risk. And there's a number of features that can indicate somebody as high risk, particularly travel history. There are some countries where hepatitis A and B are very common, and so if you are going to these countries or spent time in these countries, it might be indicated. Additionally, individuals who are not vaccinated, are HIV positive, have history of IV drug use. It's very common and can represent development of different forms of cancer and is a significant risk of morbidity and mortality. This is more, I'm sure everybody is pretty familiar with hypertension screenings at this point, but it is extremely important. Blood pressure is one of the biggest risk factors for development of a multitude of different conditions: stroke, myocardial infarction, heart failure. And so it is very important to monitor and maintain a medication regimen and make lifestyle changes that can help keep your blood pressure in a safe range. There are risk factors that put you at greater risk, including race, age. As we get older, puts us at greater risk. Family history. You will notice that family history is a risk factor for just about every condition. If your parents had a condition, you are at greater risk for it pretty much across the board insofar as health conditions. So it's always something to consider and bring up to your physician, Dr. Wright, us, or anyone else. Similarly, lipid disorder, dealing with elevated cholesterol, triglycerides, and these place you at greater risk for a similar list of complications: stroke, heart disease, which represents one of the biggest causes of mortality in the United States. This is done every 5 years. And more frequently in patients with risk factors such as diabetes and previous incidents of stroke. Okay. Diabetes, we like to screen for this every 3 years in people 40 to 70 who are overweight, have hypertension or hyperlipidemia, and family history, as because these are all potential risk factors. This can be done in a couple different ways, whether it be A1C, which is a laboratory test, and we collect that, or fasting glucose, in which we will ask you to fast prior to taking a blood sample for that measurement. It is a very common condition. It can seem mundane, but it has far-reaching effects and needs to be taken very seriously. Exercise is obviously a recommendation we like to talk about, because there's no medication we can prescribe that's quite as good as exercise. If there was, well, you'd be the richest person in the world for patenting it. But particularly in individuals older than 65, we like to recommend it for improvement of fall risk. This helps in a lot of ways. Strength training helps stave off loss of bone density. It also helps improve pain and mobility. Certain types of exercise like dancing and Tai Chi have been shown to improve balance and coordination to prevent falls. And aerobic exercise offers a multitude of cardiac and neurologic benefits. So in individuals who have elevated BMI, it's important to talk with us, to develop a plan to address your obesity and work on reducing it, because even small improvements in weight have large impacts on outcomes and health risk. It really doesn't take much to see pretty dramatic improvements. So these are some questions we might ask you, and to that very point, as little as 5 to 10% can improve diabetes. A 5 to 10% reduction in weight. So it's extremely important. Oop, what happened? I don't know why it just turned off. All right, smoking cessation. If you have not stopped smoking yet, you absolutely should. It's kind of I know that we are broken records talking about it, but smoking is a risk factor for everything, and it is the number one thing you can do to improve your quality of life and length of life is not smoke and stopping smoking. It's never too late to reap some benefits, and if you find you're struggling with that and that's something you want to work on, we have medications that can help reduce cravings. There's nicotine replacement also to that effect, and there's several different interventions, whether it be therapeutic, wherein you develop mental strategies to overcome that dependence. We're here to help in any way possible. And I won't. Yeah, the back button doesn't work. Can confirm. Well, that was just to show that there. Oh, wow, that's just a completely different place. There we go. This is just to show there are a lot of options. I know people just kind of feel like, I don't know, it's been a long time, I've been smoking and nothing worked, but talk with your doctor. We have lots of ways that we can try and help. Okay, abdominal aortic aneurysm. This is a very dangerous condition wherein there's a dilation of the lower aorta. This is at risk for rupture and can very quickly result in death. So it is very important to get screened if you are a man who ever smoked. There's smoking again, because again, it is a risk factor for everything. And so if you have not been screened, it's important to ask to be screened if you are a man between 65 and 75. Okay. But it is the 13th leading cause of death in the U.S. Okay. Alcohol abuse. Alcohol abuse is very common, and it's not something to be ashamed about. It is a medical condition that affects many individuals with risk factors. Even this has a risk factor of family history, placing individuals at greater risk. And so talk with us anytime to discuss if you would like helps discontinuing unhealthy drinking habits, or to discuss whether your drinking habits are within a healthy range. But ideally, the less drinks are generally considered the better. Okay, depression screening. We try and do this yearly. You've probably seen our questionnaires about that. The PHQ-9 is pretty frequently. This is not targeted at anybody in particular. We ask everybody these questions, and they're not to be ashamed of by any means. It's important for us to assess kind of where you are at that time, if you need help, to communicate that, and also to track if we're moving the right direction with interventions that we may have provided. So that is why we frequently provide this. And depression in elderly populations is often ignored. People often don't realize how prevalent depression is in elderly populations. But as you can see, here's a graph I was able to find, but it's common everywhere. Depression is very common into older age. And you can see females, it's higher, it's more common than men, but on the flip side of that, it's also important to note that men are at greater risk for completing suicide, especially risk factors being older age and Caucasian race are particular risk factors for completed suicide. So that's why we ask these questions, so we check in, and it's important to talk with the mental health provider if you are feeling depressed. Not to mention, depression places a multitude of different risks and health problems, greater incidence of dementia, and worse health outcomes. So it's very important. Colorectal cancer screening, already referenced at the beginning. There are a few different sort of options here with immunochemical testing, fecal occult blood tests that can be done yearly, and colonography, sigmoidoscopy, and colonoscopy. It's very important to get colon screenings as necessary, with colonoscopies being every 10 years. They're extremely sensitive and allow not only visualization, but allow immediate biopsy and sometimes small treatment should abnormalities be seen. So it really is a amazing intervention, and I strongly encourage you follow through and pursue regular colonoscopies. And this is a a bit about the kind of schema of when you can do these tests. One thing of note, these alternative equal occult blood and fit tests that can be done yearly, if they come back positive, they're not very specific, and so you do have to follow up with colonoscopy. So. And now I will pass this off to my colleague, Dr. Kuhn.
Thank you very much. Okay, so we'll just pick right up. Hepatitis C screening. So Dr. Osborne already mentioned hepatitis A and B screening. So this would be for hepatitis C screening. The recommendation is at least once an adult aged 18 to 79 needs to be tested for this. The reason for that, many patients with hepatitis C are asymptomatic. There was a study that was done from 2013 to 2016, and they found that only 56% of people with hepatitis C knew about their diagnosis. So that's why we screen asymptomatic people. Additionally, the CDC recommends screening, like I said, at least once in adults age 18 plus, and high-risk patients may need repeat screening. And then I'll talk more about HIV on a later slide. I'll talk more about these as well. This is in a table form, so if you want to refer back to it, you can. There we go, okay. So HIV screening, so the recommendation is at least once in persons age 65 plus with risk factors for HIV. Why do we do this? In 2015, there was a study that found that estimated 165,000 people in the United States had undiagnosed HIV infection. And early diagnosis usually leads to better outcomes because HIV can, you can develop AIDS from that and put yourself at risk for a whole slew of bad infections. Additionally, high-risk patients may need annual screenings, and those people are men who have sex with men, IV drug users, persons who exchange sex for money or drugs, sex partners of HIV-infected, bisexual, or people who use IV drugs, as well as sex partners with an unknown HIV status. So those people will likely need annual screenings. Low-dose CT scan screening for lung cancer. The recommendation here is a yearly low-dose CT scan of the lungs in persons 50 to 80 years old with a 20-plus pack year history of smoking and currently smoke or have quit in the past 15 years. So the way that works is if you, what is a pack year? So what you do is you take the number of packs smoked per day and multiply it by the number of years smoked. So if you smoked a pack a day for 20 years, that's 20 pack years. If you smoke 2 packs a day for 10 years, 2 times 10, that's also 20 pack years. And so who gets this? So the people who smoke 20 plus pack years and currently smoke or quit in the last 15 years. If it's been 16 years since you smoked, you don't have to do this anymore. So it's just within that 15 years of quitting. Why do we do this? Again, early detection leads to better outcomes. And if you tell a patient, hey, you need to come in and get your yearly screening to make sure you don't have lung cancer, that frightens patients and it may cause them to stop smoking. That's something that they found. So screening should only be performed when a patient is willing to undergo follow-up investigation, including serial imaging and possible lung biopsies. So if a patient says, look, doctor, even if I have lung cancer, I don't care, I'm just going to live with it, then there's no need to do this. And also studies have shown that it's better to stop smoking than to do lung screening. So if you're like, oh, well, I'll just smoke and do the yearly lung screening, you can do that and it might catch any lung cancer that comes up, but it's by far better to just stop smoking. Mammography. The recommendation is every 2 years in women age 50 to 74. Why? Again, early detection leads to better outcomes. And why do we stop at 74? The reason is that studies do not show a reduced mortality in screening women 75 or older. Now, I will say that there are some groups that recommend annual screening for postmenopausal women on hormone therapy. As well, other groups recommend continued screening after the age of 74 if life expectancy is at least 5 to 10 years. So that's not the USPSTF guideline. That's kind of standard of guideline for the United States, but there are other United States bodies that put out recommendations, and some of those recommend continued screening past 74. So those were grade. All of these that we've been doing, myself and Dr. Osborne, are grade A and B, which means very high evidence that there's going to be a benefit to the patient to do them. These are grade C recommendations, meaning that there is reasonable evidence that it will at least be somewhat helpful to do these things. And then the I means there's inconclusive evidence as to whether or not it would be helpful or not. So here's some of these screenings. I'll just talk about the bottom two right now on this table, and then the top three I'll elaborate more on those on a later slide. So obesity and undernutrition screening is something that needs to be done yearly. The way we evaluate for that is looking at your BMI. If you have a BMI between 25 and 35, it's also recommended that you further go on to have your abdominal circumference measured, because BMI can sometimes be misleading based on like muscle mass and those things. And why do we do that? Because obesity, as Dr. Osborne mentioned, is associated with coronary artery disease, atherosclerotic disease, type 2 diabetes, and many other things. Another recommendation is to take omega-3 fatty acids to prevent heart attacks and strokes. You should take that at least 2 or more times a week. Why do we do that? Because it might modestly lower the risk of cardiovascular disease. Again, this is not, hey, it's going to have a huge impact. This is it will likely help at least a little bit. Okay, so calcium and vitamin D supplements to prevent osteoporosis and fractures. The recommendation is that postmenopausal women, take both of these supplements at least once daily to prevent osteoporosis and fractures. Why? Our bones are constantly being remodeled. They're constantly being broken down and rebuilt. Calcium and vitamin D are necessary for normal skeletal homeostasis to keep that balance good and healthy. And why the vitamin D? Vitamin D also increases calcium absorption in the gut. Additionally, so this is for postmenopausal women. There is also a very soft recommendation that men and premenopausal women might benefit from taking up to 1,000 milligrams of calcium a day. And they also say in the recommendation that it's best if you get the calcium from diet, but supplements are okay if necessary. So I thought that was kind of interesting. Fall prevention assessment. So the recommendation is that this is done at least once after the age of 65. And this is when someone comes in and looks to see what does your home look like, your situation, and what is the risk of a fall in that setting. Why do we do this? The risk assessments have shown to decrease the rate and risk of fall in patients with a high fall risk. And so what are some of the things that might be recommended to you if you undergo a fall prevention assessment? It might be recommended that you have stair handrails installed if you have stairs, grab rails in the bathrooms like next to the toilet or in the shower, improved lighting in your living room, non-slip bath mats, as well as they may issue you a home safety pamphlet you can look over and kind of will give some of these recommendations. Okay, so this one is kind of an unusual one for me. I was really surprised to read this. So measurement of serum CRP. CRP is a general marker of inflammation. It's something that we don't really think of as really specific. It's just if you have general inflammation in the body, this will be elevated. It might be from an autoimmune condition. It could be from an infection. But there have been studies that have shown that I'll tell you that in a second. So the recommendation is to measure this at least once in patients with at least one risk factor for coronary artery disease. And why is this recommended? There's a study that's shown that on patients on a statin, so like a torvastatin, Crestor, something like that, elevated CRP, which is a marker of inflammation, is associated with major adverse cardiac events. For these patients, residual inflammation may be a stronger predictor of coronary vascular risk than LDL, which is a bad cholesterol. So these are patients who are already on a statin. This isn't just the general population. Patients who are already on a statin, it's recommended that you look at their CRP level to see what their risk is for cardiovascular risk. And one other thing that they mentioned is how do you lower your CRP if it's elevated? Statins are actually shown to lower CRP. So that's a good thing, right? And if you're already on a statin, then hey, you're already on one of the treatments for having an elevated CRP. Statins are shown to lower it. Also, diets rich in fiber and vegetables can also lower CRP. So these are recommendations for secondary prevention. So if you already have some of these illnesses, then these are things that are recommended to you. So like a yearly skin exam, yearly cognitive impairment or dementia screening, glaucoma screening, hearing impairment, TSH, which is the thyroid hormone, visual impairment screening. These are all things that are recommended to be done yearly. And then just to talk a little bit more about colonoscopies. So Dr. Osborne talked about the different ways in which you can screen for colon cancer. This is if you have a colonoscopy, what is the interval at which you should come back for a colonoscopy? So and I also color coded it. So green is low risk, yellow is moderate risk, red is high risk. So one other thing that I will say is that we are talking about, hopefully y'all can see this. We're talking about this region here, benign lesions. If you have cancer in the colon, that's totally different. These are not talking about frequencies for that, because if you have cancer in your colon, you're gonna have to have recurrent colonoscopies every 3 to 6 months for like a couple of years. Like it's a totally different recommendation. So these are just benign polyps. This is what I'm talking about. So if you have a normal colonoscopy, there's no polyps at all. Every 10 years is the recommendation. If you have 1 to 2 polyps, each smaller than 10 millimeters, 7 to 10 years, and you can kind of read on, going down through that. The more polyps you have, or the larger they are, the more frequently you need a colonoscopy, and so that kind of makes sense. One last thing I'll say is this little asterisk here on the bottom. Most cancer screenings do not realize a survival benefit for the patient until after 10 years from the time of the test. Because that's what we're trying to do. We're trying to prevent mortality and morbidity from a disease. And you need time for that prevention to have a benefit. Cancer screening should be discouraged or very carefully considered in patients with 10 or fewer years of estimated life expectancy. That's kind of the general recommendation. Not to say you can't do it, but you have to think, it's not to say you can't do it after, this age, but just you have to think very carefully about, if you had colon cancer, would you really want to go through with the treatment of it, So it's kind of a case-by-case basis. And these are things that the USPSTF says do not do. So a screening for asymptomatic bacteria. So what that means is screening just random patients that come in for a UTI who don't have any symptoms of a UTI. So, hey, I have UTI sometimes. Can you just screen me for it? We're not supposed to do that unless you're actively having symptoms from it. Coronary artery screening for coronary artery disease without any risk factors. Screening these cancers, just for no reason. And then also another thing that they say is don't screen cervical cancer in women 65 plus who have had adequate prior screenings and not at high risk. So if you're over 65, you don't, obviously need pap smears anymore. They say you don't need to continue screening for prostate cancers in men over 70. You don't need to keep doing colon cancer screenings in patients over 85. So those sorts of things. And these are our references there. And that's the end of the presentation. Do y'all have any questions?
So generally it's recommended at least once, and so follow-up evaluation can be to see if you have evidence of antibody response to previous vaccinations. That can be performed to make sure that you still have resistance and have no evidence of disease.
No, it shouldn't have said that. It's the two-part, the Shingrix that's available now. Everybody should get, even if they had the old single shot thing, and even if they've had shingles, they ought to have the Shingrix two-part, two-shot thing. But once you get that, you're good for life. Yeah, you shouldn't need, let alone yearly. So that was some kind of mistake.
Yes. Yeah, so eggs come up pretty often because they do have cholesterol in them, and so the thought process is, well, we should avoid them to avoid increasing our cholesterol. What we're finding is that that sort of dietary intake of cholesterol isn't a huge factor. There's certainly individuals with genetic predisposition to hypercholesterolemia who might be counseled to avoid eggs because they indeed might be having difficulties processing cholesterol. But generally, for most healthy individuals, eggs are okay.
It really has fallen off the bad list in recent years, and that's a good thing. But it's on the good list for protein. Great source of protein. Yes, ma'am. Let's just hand these out. Sorry.
What about the RSV shot, the vaccine for that? Are you recommending that for those of us over 65?
Yeah, it should be an annual vaccine.
Hand your mic, if you will.
Beside getting the flu shot, which I think we can have here this week actually, and then we get another shot in the other arm, and I'm trying to remember what that is for.
COVID.
The COVID, all
How
right.
can we forget?
But then, is there a third shot that I have been reading that perhaps has been recommended? And what is it? Say
Sorry,
it,
just
say it.
So it's that third shot's the RSV vaccination. Yes, ma'am. That's going to start this year. Yeah. Yes, ma'am. And I believe that's going to be offered here as well. But anyways, it'll be an annual vaccine that you'll get with your flu shot in the fall. Yes, ma'am.
This is an area
RSV.
you ordinarily don't.
So what we're recommending is to not do all three on one day.
I'm sorry, I didn't. Yeah. I think it's a month. How long to wait? But you know, I'm not sure. I'm going to have to ask Carl Collier.
So what we have been recommending is to not get all three of those vaccines, the COVID, the flu, and the RSV vaccine on the same day, but you can do two on one day and we've been recommending to wait a month and come back for the third one, whichever the third one is. It's a virus called the respiratory syncytial virus. It's a virus that infects infants as well as older adults. So it's likely that if you have any grandkids who are young, they may also have RSV. They can get it at school, and then the risk is that you could potentially get it as an older person and be at risk for serious complications from it. So it's a new vaccine that's come out for young children as well as for older adults for that reason.
What's the other one? The flu?
The RSV,
No, flu and COVID together and wait 2 months. Dr. Wright told me this, I believe. Wait 2 months for the other.
I think that's 2 months if you've had COVID. 2 months from the time you had COVID. Right.
Yeah. Yeah. It is.
May I add a little bit of information to this, and that is that it's perfectly all right to get both your flu shot and your COVID shot the same day. It is to your advantage immunologically if you'll get the same kind of shot in the same arm that you got before. In other words, if you happen to remember that you got your flu shot in your left arm, have that flu shot again in that left arm. The same is true for COVID. It is not recommended at all that you get the respiratory syncytial virus at the same time. Also, it's important to get a good night's sleep before you're immunized because, again, you'll get a better immunological reaction. So those are the comments that I'd like to make, and I think they're pretty valid. I have some questions, but I'll turn it back over until I get a chance to ask those questions. I think you did a great job in covering all of the things that one can do to help maintain a healthy life. I'd like to ask both of you, though, because I think it is extremely important in what to expect in the future about these kinds of things, and that is, I'm very interested in the fact that you can do a genetic analysis and find out a person's predisposition for certain kinds of diseases that put one on guard that you might not otherwise know about, together with the fact that a genetic analysis also will indicate what medications will be most appropriate in certain diseases. What do you think about that for the future?
I totally agree. I think that is where we're heading with medicine. We're just not quite there yet. The cost of whole genome sequencing is still quite expensive, and we don't have, honestly, there's not the staff in the United States to interpret those things, because interpreting a whole genome sequence is very time intensive. Yes, but it is coming. Yeah, so the more people need to get into that career to help the throughput of interpreting those results, and we need to get the cost down. But you're exactly right, and there are some people who, so for example, statins. Some people don't respond to statins, and we may not realize that until they have a stroke on a statin. And we're like, oh, well, they weren't a statin responder. We didn't know that. If we could get that off early, find that out early through a genetic test, that would be really a good thing. I agree with you.
Your presentation really made me think about a lot of things. One of the things that I wish you'd had time to cover, and that is lifestyle. That makes so much difference in the development of various kinds of diseases. For example, what can you do to try to put off or prevent dementia? What's the importance of sleep? What's the importance of nutrition? These are the kinds of things that I think we really need to take very seriously because it can make a difference. And also the importance of the new studies in longevity that emphasize these kind of things. So there are 3 or 4, maybe 5 bedrocks of what everybody ought to be practicing if they want to live a really good, good, normal, healthy life to old age. Would you comment on that?
I totally agree. I'm not going to disagree with that at all. Yeah, so things that are, you kind of mentioned dementia, things that are good for the heart are also good for the brain. So, because it's all about blood flow, right? So, if you want to do things that are good for your heart, those are things that are also probably going to benefit the brain. So, yeah, exercise, a low-fat diet, yes, definitely, I agree. Sleep, if you can reduce inflammation, like we were talking about with the CRP marker, things that diet that is high in fiber, low in fat, those things, high vegetable diet, those are all good things that are good for the brain. I agree. C-reactive protein is what it stands for. Yes, ma'am.
On the point you mentioned about genetics and the direction it's kind of headed with treatment, it is headed that direction where we are finding certain gene markers in some cancers and in some healthy individuals that correlate with certain drugs. But not only is full genome sequencing, it's not simply a matter of that we don't have your whole genome, or it'd be too expensive to do so. As we kind of plunge further and further into that question, we realize how much more complex it is than we realize. With it's not just what genes you have, it's what genes are turned on, what genes are turned off, how many copies of them you have, what your gut biome is, what bacterium and organisms live in your gut and help process all these things. And what we're quickly realizing is that the questions are a lot bigger than we realized. As is true with every scientific development, there's more questions than answers. But it's been in the news every day, 1,000 times a day. I am interested to see the ways in which artificial intelligence will be able to have more complicated and nuanced explorations of associations between our genes and certain factors that would be harder to otherwise extrapolate by humans researching. So I think that that'll be an interesting tool moving forward with those sorts of questions.
It's a really important topic and a great question and explanation, Helen. I think right now we're kind of nibbling around the edges of understanding of this topic. It's so huge. We're gonna look back, maybe not in my lifetime, maybe not in yours, but we're gonna look back at this as the dark ages. We suspected a lot of things and we didn't know much. And so we apply the things we understand best to everybody, even though if we were really able to utilize these new technologies fully, we could identify who would benefit and who won't. That's the exciting thing coming in medicine. These guys may be able to appreciate that and incorporate it in their practice. I'm sure I won't. Yes.
Of the 3 shots coming up, which one should we save for last? And if you have a lung problem, is it important to get the RSV first?
I don't know about that last question, honestly, do you? I think what was said a while ago by someone that the COVID and the flu taken together is fine, but it ought to be separated from the RSV. And ordinarily we're thinking of the RSV being the third one, but I'm not sure how important that is, or whether it would be more important with lung disease to have you heard?
I have not heard an official recommendation for patients with chronic lung disease, which ones are the most important. Just my rationale, which is frequently faulty, my rationale would say that if you have a chronic lung disease, that you would be at risk for complications from all 3 of those.
Yeah.
So it doesn't really matter. It wouldn't really matter which one, as long as you get all of them. But there might be an answer out there for you. I'm unfortunately, I don't know if there is or not.
You haven't said too much about sugar, but I have Sjogren's syndrome, and I'm losing my sense of taste. I can tell if it's salty, if it's bitter, if it's sour and sweet. And I think I'm addicted to sweet. So, what can I do?
You know, I tell people all the time that sodium, which we want people to cut back on, you can retrain your salt taste if you're deliberate about it. It's hard to cure a sweet tooth. That's maybe impossible.
Yeah, that's challenging. And that's true. As we age, even in the absence of any condition, smell and taste decline, and that can be like wanting to get more flavor out of things. We add more sugar and more salt to try and counteract that. It does help to do some of these measures. And they are coming out with, it's a great time for avoiding sugar in some ways. We're getting very good at making things that are flavored more based on their smell, because actually most taste is derived from smell. And so, having scented drinks will sometimes trick your brain into thinking that it's tasting sweetness even when there's none there, and things like that. It's quirky little tricks you can play on your brain.
Zero sugar. Zero sugar.
Zero sugar.
I just had a friend that went to Collier's yesterday. The COVID shot was not available. She got the flu and the RSV.
Okay.
Now, what happens if the COVID is available next week when they come out for the morning?
I think it will be, because I thought it was coming out this week.
Right, well, she went yesterday and it was not available, the
Okay.
COVID shot.
Okay.
Okay, now let's say we go in Thursday and it's not available, but the RSV and the flu shots are, and we get those. And then let's say next week the COVID shot is available. Then we are not to take it, and then are they going to reschedule the clinic so that we can get COVID?
I don't know. I don't know right now the answer to any of that, but I know there will be an answer, and because this is being distributed in a real regimented sort of way, there'll be an answer for every one of those questions. And if I tell you what my inclination is,
Okay,
if I'm
but
wrong, I'm deferring to that future
But you would
question
feel
answer.
it would not be
Yeah, sure.
appropriate to do the third shot a week later, is that correct?
I can imagine that they might have pronounced it by then. The CDC and others have pronounced it okay.
Okay,
But so I don't know. My inclination right now is to take two, and the third one a few weeks later.
okay.
But I'd be happy to be told otherwise. And I imagine by the time Carl Collier comes out here with those vaccines, he's going to have all those answers, because he's going to have it scripted by then. Sorry.
Okay.
Good questions. Hard questions.
I was told humming is good for the brain. What's your take?
What is good for the brain?
Humming. I go down
Humming,
the hall and
humming.
I hum.
It doesn't sound like a rumor a person would just make up for some benefit, so I don't. Must be something to it. Oh, you saw an article. It's in writing. It wasn't in social media. Okay. I don't know. I'm just kidding.
I've read something similar. I don't know if it's the same article or not. I've read something similar. I think, this is in the recesses of my brain here. I think the reason for it is that studies have shown that humming can increase the release of vasodilatory hormones in the bloodstream that increase blood flow to the brain. I think that's why. I think that's the rationale behind it. But don't quote me.
That coupled
They might
with
also
the,
just like your humming. I don't know.
that coupled with the truth that we all know that music is therapeutic, I would guess it has something. There's something to it.
And just one more element, because to throw something to that, do you enjoy humming? Because like I mentioned a little bit earlier, depression and these sorts of things are associated with dementia. So if it's making you happy and making you more engaged and you're humming along as you're doing more activities, it will absolutely help.
Solid rationale. Thank you all. I so appreciate your attention and your participation.